Welcome to this explainer. Today, we're going to demystify the ECG criteria for left ventricular hypertrophy, or LVH. It's kind of like a giant puzzle. We're going to take you on this really fascinating journey, basically mapping the physical anatomy of a thickened, overworked heart right onto the electrical signals you see on a standard piece of paper. Whether you're literally looking at your very first tracing right now, or you're just here to refine your diagnostic eye, understanding how extra muscle mass completely alters electrical voltage is just, well, it's incredibly rewarding to figure out. Okay, let's dive right in and look at this striking visual difference. Just compare the normal heart's electrical footprint to the one with left ventricular hypertrophy. Notice how the normal tracing looks, relatively balanced, but then look below it. The LVH tracing looks wildly exaggerated, almost like someone just cranked the amplifier all the way up. So we're going to explore exactly why the hypertrophied heart turns up the volume on these specific electrical vectors, and more importantly, how you can spot it with absolute confidence. To navigate all this, here's our roadmap for today. 1. Understanding left ventricular hypertrophy. 2. The core ECG indexes. 3. Recognizing secondary STT changes. And finally, 4. Pitfalls of amplitude measurements.
All right, let's jump straight into section 1, understanding left ventricular hypertrophy.
Before we get into measuring the waves, we really have to understand why the heart grows in the first place. Honestly, it helps to just remember that the heart is, at its core, a muscle, right? And just like your biceps bulk up when you're lifting heavy weights at the gym, the left ventricle physically bulks up to compensate when it has to work too hard against severe resistance. The most common conditions forcing this intense workout are things like aortic stenosis, aortic regurgitation, chronic hypertension, various cardiomyopathies, and coarctation of the aorta. Basically, the heart is adding physical muscle mass just to keep pumping blood effectively against these massive barriers.
And here's where it gets interesting. That physical bulk translates directly into a massive amplified electrical vector. Because there is quite literally more muscle tissue sitting on the left side of the heart, the overall electrical signal just shoots heavily to the left. So when you look at an ECG, this amplified leftward vector creates distinctively huge R waves in the left-sided leads. Think V5, V6, lead I, and AVL. And at the exact same time, it leaves behind these really deep S waves in the right-sided chest leads, primarily V1 and V2. Moving right along to section 2, the core ECG indexes. So how do we actually measure that amplified vector on the grid? Well, we use mathematical rules, and the most widely used one globally is the Sokolow-Lyon index. It's actually beautifully simple. You just look at the depth of the S wave in the right-sided leads, either V1 or V2, and you simply add it to the height of the R wave in the left-sided leads, specifically V5 or V6. If that combined total is greater than 35 millimeters, boom, you meet the criteria. Oh, and alternatively, an R wave in lead AVL that's greater than 11 millimeters also triggers it. Now here is an absolutely crucial point about the statistical reality of the Sokolow-Lyon index. It actually has a shockingly low sensitivity, sitting right around just 20%. That means it's going to miss a vast majority of actual LVH cases. However, its specificity is incredibly high, well over 85%. What does that mean for us? It means if you do the math and the result is over 35 millimeters, it's highly, highly likely that true left ventricular hypertrophy is present. It's a fantastic tool for ruling it in. Next up is arguably the best overall index, the Cornell criteria. What makes the Cornell criteria so clever is that it actually accounts for physiological differences by setting completely separate thresholds for men and women. So for men, you add the S wave in V3 to the R wave in AVL, and you're looking for a sum greater than 28 millimeters. But because women naturally have slightly lower QRS amplitudes, the threshold for women using those exact same leads is lowered to greater than 20 millimeters.
And just like our previous index, the Cornell criteria has a modest sensitivity, capturing roughly half of the cases, but it boasts a massive 95% specificity. By taking the time to adjust for gender, it totally refines the math. That makes it an incredibly reliable confirming tool when you're trying to figure out if a patient has a thickened left ventricle.
Now, if you want a more comprehensive picture, we use the Romhilt Stay Index. This is a bit different. It's a scoring system rather than just a simple mathematical sum. You basically rack up points for high amplitude, ST changes, left atrial enlargement, axis deviation, and QRS duration. If you score 4 points on this table, LVH is probable. If you hit 5 points, it's very likely. It's great because it forces you to step back and look at the entire electrical environment of the heart, the whole shebang.
All right, on to section 3, recognizing secondary STT changes. Because diagnosing the heart isn't just about measuring wave height, right? It's also about the shape. But first, a really quick terminology update. If you've been around the medical field for a while, you might have heard older practitioners refer to the strain pattern. People used to think this pattern literally meant the left ventricle was exhausted. But actually, scratch that, we don't use that term anymore. We've learned that these specific electrical changes also happen in conditions where the left ventricle isn't overloaded, like dilated or hypertrophic cardiomyopathy. So the correct modern terminology you really should be using is secondary STT changes. Let's see what those changes actually look like in practice. Draw your eyes over to the left-sided leads. Notice that J-point depression right after the QRS complex, and see that downsloping ST segment? Notice how it typically bulges upwards in this convex shape, feeding right into an inverted asymmetric T-wave? Meanwhile, if you look over on the right-sided leads, you might see a slightly concave ST segment elevation. These specific contours are an absolute hallmark signature. They tell us that the repolarization of this massive muscle has been fundamentally altered.
But wait, there's more. Beyond the ST segment, there are other supportive clues scattered all across the tracing. Because it takes longer for the electrical signal to depolarize a much larger mass of myocardial tissue, you might spot a slightly prolonged QRS duration or a notched appearance. You'll also often see left axis deviation. And since LVH creates this backup of pressure that affects the hemodynamics of the left atrium, you'll frequently see P mitrale, which is the classic ECG sign for left atrial enlargement. Honestly, you might even spot a slight QT prolongation.
Which brings us to our final part, section 4, pitfalls of amplitude measurements.
Now, here is the major caveat to literally everything we've just talked about. Relying solely on the math behind these indexes is inherently flawed. Why? Well, the core problem is that QRS amplitude is heavily affected by factors that have absolutely nothing to do with ventricular mass. The physical distance between the heart and the skin electrodes changes the game entirely. For example, a lean body configuration means a shorter distance, which naturally boosts the signal amplitude. On the flip side, in an obese individual or someone with a hyperinflated chest from COPD, that distance is much greater. This dampens the electrical signal, which can falsely hide a truly hypertrophied heart.
Age. Age is another massive confounding factor. QRS amplitudes naturally diminish as we get older. This means that young, healthy individuals naturally project much larger QRS amplitudes. Because of this physiological reality, some experts explicitly warn that these ECG indexes for LVH shouldn't even be applied to patients under the age of 35. The false positive rate is just way too high. Which brings us to a classic trap. Picture a 25-year-old athlete. Their completely healthy cardiovascular remodeling often produces these huge QRS amplitudes that perfectly mimic pathological LVH on paper. So ultimately, what you should really take away from this explainer is that you can never ever let the math blind you to the context of the actual person sitting right there on the exam table. The ECG is an incredibly powerful tool, but if a tracing is just screaming LVH, you have to ask yourself, does this actually fit the clinical picture, or am I just measuring the natural voltage of a young, healthy heart? Keep that question in mind every single time you find yourself counting those little squares on the grid.